Hello, everyone. Welcome back to Bond Air. My name is Jesse Longo. I'm your host, Associate Director of Nursing here at Bond, joined today with my trusty sidekick, Dr. Jeremy Kimmelstiel. How you doing?
I'm good. How are you doing, Jesse?
I'm doing good. I'm excited today because I listened to that Christina Aguilera 25th anniversary of Self-Titled when I was coming into work today, and let me tell you, if I could sing like that, I would only sing. I would never talk. But that is neither here nor there. I am also feeling good because we have a returning guest. Today we're joined by Dr. Justin Carlson, a board-certified veterinary cardiologist here in New York. Dr. Carlson earned his VMD from the University of Pennsylvania, followed by an internship and cardiology residency that took him from New York City to Texas A&M University. For nearly a decade, he has been practicing in New York, providing specialized cardiology care to pets. In this episode, we'll explore recent publications in veterinary cardiology and discuss how primary care veterinarians can build stronger partnerships with certified specialists to enhance patient care. Last time we had Justin on, we were talking a lot about his brand new standalone specialty practice, TACS, or the Animal Cardiology Center in Dumbo. So we're really excited to have you back on. How have you been? How's everything going?
I've been really good. It's been a year and a half since I've been on with you guys. So TAC has been really busy. We added 2 associate cardiologists, so there's now 3 of us, which is really exciting. And we're also offering appointments on the Upper West Side. So not only Dumbo, but Upper West Side, canine and feline patients can see us, which is exciting.
That is exciting. Expanding the footprint.
Yeah, it's been, I think, for those of us who have been referring patients, I think we've noticed that there's been an expanded footprint and that there's been a little bit more availability than even there was originally. And that's been, I think, great for our veterinarians, certainly for our clients. We even went outside of the protocol and reached out to you recently about one of our own employees here who needed some help, and you were really helpful with that. And so the relationship is growing, and I know it's been a year and a half since you were on the podcast. We've seen you a lot of other times in ways that you've been sort of helping lecturing our doctors, our MAID program, and accepting interns into your practice to continue the teaching. So we're super appreciative you're here today, but also super appreciative for all that you've done in the last year and a half for us.
Yeah, I love to do it. So it's, cardiology is my passion. Sadly, I'm a big nerd in multiple ways, but I think if you find something you love doing and that's your job, then it's not really work. So
Absolutely. I think you're in good company and a table of big nerds here as well.
Speak for yourselves.
Yeah. Oh, man. You bring up a really good point, Jeremy, about the collaborative care that we have been partnering with Justin and his team over the past year and a half. And as we have kind of been doing that naturally without even realizing, because I think Justin sent us over a study that was done in 2016 titled The Impact of Collaborative Care on Survival Time for Dogs with Congestive Heart Failure and Revenue for Tending Primary Care Veterinarians, that focuses a lot on the power of collaborative care. Justin, I think I've obviously you sent it over because you felt passionate about it and wanted more people to hear about it. So you have the floor. I would love to hear kind of your thoughts on this and how you've seen it come into practice.
Yeah, so I think it's a study that very few people know about. It was in the 2016 JAVMA, which should have a good readership of general practitioners. I think a lot of times when we think about publishing things, or at least a lot of my mentors would talk to me about this when we would do studies, and we would then say, where do we want to publish this? So yes, if you put it in JVC, every cardiologist will see it, right? That's the Journal of Veterinary Cardiology. But how many primary care clinicians are reading that? Probably very few. So you have to figure your impact factor based on who you want your audience to be. So I think whoever kind of had this first idea probably thought this is the best place to put it, but I don't think it actually reached as many people as you would hope, because, I'm sure you guys read through it thoroughly, and then when you actually come to the results and the discussion, it's quite eye-opening, because it's not something that is done in New York City. I think it's actually contrary to what the popular belief of what we can do as far as care for our congestive heart failure patients.
Maybe you can just quickly talk to us about what the study was. So what were we looking for? What was the hypothesis? And then, a little bit about how that was measured going through the start of the study.
Yeah, so it was a retrospective study, which we'll talk about the limitations, but also why it had to be a retrospective study. But, looking at patients who were in congestive heart failure, who were either treated only by their primary care clinician, their survival time and how they did versus, dogs that had congestive heart failure that were treated by their primary care clinicians, referred to a cardiologist, and then continued collaborative care between those two. And then looking at those records and seeing not only how they did, but also the revenue generated for the primary care clinician, which kind of sounds a little icky when you think about it, but this came out at a time after when a lot of our specialists were, we were starting to turn out more specialists, and I think primary care clinicians were starting to get really worried that they were losing a lot of their revenue. So the secondary hypothesis was that it doesn't actually take revenue out of the primary care clinician's pocket. Their patients will live longer. They actually end up generating more revenue. So it kind of sparks a little bit of a reaction when you read that in a title, but I think when you get all the way through it, it's really interesting.
Yeah, I mean, we talk about value and a lot with what we do, and so I think value can be the actual dollars that are spent and what these veterinary clinics are making, but I think ultimately what you end up seeing is that revenue is sort of directly correlated to the trust of the veterinarians, and I think that that relationship that gets built between the client, the primary care veterinarian, and then the specialist. And I think we can talk about this more broadly and then more specifically with cardiologists. But I think more broadly, the when there's a great referral that happens from a primary care veterinarian to a specialist, and then there's a lot of interplay back and forth, trust becomes the real the real value that we gain from these interactions and relationships.
Yeah, absolutely. I think one of the internists that I met as soon as I became boarded and started working in New York, Larry Berkowitz, one of the things he said to me, which has stuck with me for my entire career, is just do really good medicine and money will always follow that. And it's 100% true. And that's all I've ever worried about is really good medicine. But the trust and the relationships that you build are also really important. There's a similar article to this one about oncology patients. And what they actually looked at in veterinary medicine, veterinary oncology, was that the trust that the clients gained for their primary care clinician increased when they were referred to certain specialists, mainly an oncologist. So that might be something you guys are interested in reading too.
We talk a lot about access to care as much as we talk about value, and it's something that even throughout this paper study they talk about when it comes to how the clear role the primary care clinician plays in facilitating that care with the specialist.
Yeah, I mean, in this study, they made a big distinction between referral to an in-person appointment with a cardiologist. So this is not a traveling ultrasonographer. This is not a traveling cardiologist. This is very specifically them sitting and speaking with the cardiologist, because that cardiologist educates that client a lot more, which is a huge part, right? That's the person that is measuring respiratory rates, noticing these things at home, and being able to know what's a problem, what's not a problem, so we don't get into those emergent situations, and we can then call our primary care if it's a problem that is not related to cardiology versus calling our cardiologist if it is a problem to deal with cardiology. So I think that was a really, really key distinction in this study.
I agree. I was going to point it out as potentially like a risk in the study too, because you're sort of self-selecting for a client type that is going to be, maybe a bit more, might adhere to some of the recommendations a little bit closer. You're also talking about a population that is around a boarded cardiologist, which might be, in the cities or near universities. And so that could be a component of the risk. But I think ultimately, if we're to look at this from the 30,000-foot view, there's this sort of importance of teamwork. And that teamwork is, true in a clinic where you have two primary care clinicians sitting side by side. I think the patient care and the client experience is better when we have two veterinarians working on the same day. In the same sense, when we have two veterinarians, one a specialist, one a primary care clinician, who working together and sort of bridging that teamwork.
Absolutely. And I think it goes beyond treating the congestive heart failure. There are tons of times where I'll see that patient, I'll do a full physical examination. I was trained by my mentors that yes, we're cardiologists, but you pay attention to absolutely everything. And I'll find, an enlarged lymph node. The popliteal lymph node is a little bit bigger. I'll call, you, if it's your patient, we'll chat about it. I'll be like, hey, I'm telling them to make an appointment with you. I want you to see what you think about that. Check that out. You aspirate it. We find lymphoma and end up starting treating that. And that dog lives much longer because we found it so much earlier. It's kind of very interesting how many cards I get from owners about finding other things other than the heart failure that I'm treating.
Right.
They're just so thankful for that. But it's because I have a good partner to do that with. If it was one of your patients, Jeremy, asking me to try to aspirate a lymph node these days, I don't think I would hit the lymph node at all. So that's why we have to work together to do those things.
We've been, I think, hugely appreciative of, there's been a couple of specialists who have joined us on this podcast, and that sort of feedback loop has been, I think, hugely effective, both for our clients, but also for our clinicians, that when we send patients there, that we're getting, the type of feedback that is necessary from the specialist. So not only yes, I'm following up with you, you were spot on with your diagnosis, this is what we're starting, but also, maybe you missed on something, and that's okay. I'm just going to tell you, I'm going to try to give you a couple of pointers of how to, address that in the future. And I think we've been really, really appreciative of that component of working with you.
Mm-hmm. Yeah. And I mean, what owner is not going to be happy when, they find out that their specialist is talking to their primary care, they're having conversations about their dog. They're like, well, that's amazing because my dog is clearly getting great care. And that's what happens. You guys bounce other ideas off of us. Maybe you're even, usually when I call you guys, you're like, oh, while I have you on the phone, there's this other case. And then, so it just sparks more conversation, which is just more, intellectual growth.
Yeah. So let's go back into the study a little bit.
Yeah.
The results were remarkably positive on both sides. So, the measures were survival time and then revenue generation for the primary care clinician. So what did those results show?
Yeah. So, well, not that this is going to be a podcast on how to read a study, but I do think that that's something that we touch on a little bit in vet school, but really in your specialty care residencies, that's where you learn these things. So one of the first things to think about is you look at the study at face value, then you go to the results, you're like, oh, that's great. But first, who did we look at? Okay, we were looking at dogs who were in congestive heart failure. So then you want to say, okay, well, what kind of dogs get that disease? And is this patient population the same as that, right? So we're looking at our old, smaller breed dogs. It's the same sort of way if you're reading a paper about hyperthyroidism, you expect to read a paper about old cats, right? If it's young dogs, you're thinking, well, this is really strange. So anything that we kind of draw conclusions to, that's not going to hold true to my patient population. So yes, they were small dogs, right? They were less than 30 pounds. They were over 9 years of age. And so this is the right type of dog to get this disease. Great. So we're in the kind of right population. And then you say, okay, these are dogs in congestive heart failure. How long do they normally live? What are the reported norms? Does that match up to what we found? Or did they find something super, super weird? And it does, right? We know that these dogs usually live somewhere between about 9 to 12 months with, continued care. So there were 26 dogs that fit all the requirements when they looked at it retrospectively. 18 had collaborative care, 8 had primary care only. And the median survival time was 254 days for the collaborative care, which is about 8 months, which again, that fits with what we were saying. And then only about 5 months or 146 days for primary care alone, which about 10% of those dogs lived 1 year, whereas 75% of the collaborative care dogs could actually live up to a year. So it's a big difference. But the main thing is when we look at these things and we look at Kaplan-Meier plots and we look at statistics, which I am not great at that by any means. There are people who are much better at it. But then usually when we do these studies, we look at something called the hazard ratio. So the hazard ratio is the risk of having a hazardous event. In this paper, we were looking at cardiac death, so time to death. And so your hazard ratio was 0.2 for seeing a cardiologist, which meant that it was 80% lower for you to die at any time period along this study. So if you saw a cardiologist and your primary care clinician, you were 80% less likely to die than if you did not see a cardiologist in person.
Pause right there.
Yeah.
So what do you think are some of the contributing factors that, that relationship and having seen those two sets of veterinarians, what do you think that, led to those types of numbers?
Yeah. So I think you're probably seeing doctors more often, right? So there's more time points on the line where we can catch things. I think more people are telling their owners about what's important. They're getting re-educated. I mean, how many times does someone come into your office and you tell them everything at the first appointment and they remember all of it? Almost never. So the more times these people hear how they should be monitoring the resting respiratory rate, how important it is to give the medications, yes, every day, yes, twice every day, that sort of thing. When you hear it once from one person, maybe it doesn't stick. When you hear it multiple times from multiple people, you're a team, right? You really feel like you need to do these things together. So I think that's definitely one of the things that really helps.
I think, engaging the clients in the recommendations is kind of important. And yes, I think repetition is hugely important as well. I mean, it's probably important for our veterinarians too. I mean, again, if they're seeing both the specialist and the general practitioner, they're probably, getting a bit more solid in the types of recommendations for this particular case, which can have plenty of nuances.
Yeah. And I think one of the things too that is hard as a primary care clinician is knowing when to refer, right? I think the study even kind of comments on that sometimes as general practitioners, you struggle to know when to refer. And so I think this actually draws a nice line in the sand to say, okay, once they go into heart failure, we should get a cardiologist on board and you should talk to him or her and go to their clinic and actually see them in person. You'll still see me, don't worry, but I think we need to pull in someone who can elevate it, can help.
I think it's a good place just to expand on that with a little bit of your own experience. So just outside of the paper. So what are some of your thoughts on when is the best time for referral? Yeah.
So I think it's a little tricky to say, all things being equal, right? If you could do anything, take what we do for ourselves. We talked about the last time I was on, we talked about my hip replacement. And so obviously I do informed consent for my own medical issues. But I went to multiple orthopedists before I had my surgery. So, I think the thing is the more people you can talk to, the more information you can gather, the better. So it's never wrong to see another doctor at any time point on the line. If you have really mild disease, okay, maybe that's a little bit overboard. But not to kind of go back to the stats, but the hazard ratio of being 0.2. So to put that into context, one of the studies that I know you've read, the EPIC study that looked at using vetmedin in dogs who are, B2, so not yet into this stage where we're in heart failure. We know that those dogs need that medication. There's an overwhelming benefit to it. The hazards ratio for that was 0.5 to 0.6. So that's, you get the vetmedin, so your chance of going into heart failure is, decreased by about 6 to 40%.
But who's counting?
Yeah. But in this study, we're decreasing your likelihood by 80%. So you're 5 times more likely to die if you don't go to a cardiologist. So really there's never too early to go. But I think once you're in heart failure, I definitely think you should at least have one conversation with a cardiologist. And then, once we start requiring cardiac medications, that's a good time too to say, hey, this is a cardiac med. The person who has the most information about this medication is a board certified cardiologist. It might be nice to talk with them in person because there are some nuances to vetmedin too. We have concerns about compounded pemobendin, its dissolution rate, and therefore its absorption. And that's something only, we as cardiologists talk about very often. Mm-hmm. So there are small things that we add benefit. At least, I'd like to think I do. If I don't, then geez. But yeah, I think it's never wrong to see a cardiologist too early. But I think in my practice, or what I would tell my parents with if they had another dog, I would say once you start to require medications for a disease, maybe just talk with the specialist.
So this is the last question I'll ask on collaborative care, and then we can switch gears a little bit. But this is more of like a client journey question. So it's not going to be so much in the minutia of the science and some of the work you're doing, but occasionally we'll have a client that will have a mobile ultrasound done with us. There's significant growth of the size of the heart. The left atrium is huge. It may be it's one of these situations like heart failure could be tomorrow. It could be in a few weeks. We take the chest x-rays. We don't necessarily see any evidence of heart failure, but those are the cases where it's like, really now is a good time for you to start meeting with a cardiologist. Like, I know we've been trying to avoid this, but now's a really good time. And I'd love for you to do it in the next couple of weeks. What does that look like when that client then comes to you and they just spent a lot of money on an echocardiogram with us, with a mobile ultrasound? Is that something that you're going to 100% repeat the images right then and there? Or are we going to sort of get the conversation started and plan for the next echocardiogram down the line?
Yeah. So I can't speak for other practices. I can only speak for ours, but yes, I am a bleeding heart. So yes, I discount a lot of the things that we do if they've just had things done. We have recheck fees, we have abbreviated fees and things like that. So if they just spent that, then yeah, I'll absolutely discount it. I'll ask to get the images and the cine loops. Unfortunately, I can't get those. So if I could get those and look at them, make my own measurements and things like that, I would. But unfortunately, that's not the practice, which we won't get into the legality of that. I don't know how much that affects you guys, right? You have to keep medical records for 5 years. So if we don't have those images, that could be a problem. But we'll discount it for sure. And I don't know, there can be changes, from day to day, not only week to week. So I think not repeating it could be doing them a disservice for sure.
Right. Yeah. I mean, the reason I asked the question is not really to, find out, all of the ways in which, we can sort of extend each dollar between our two practices, but rather trying for us to start to determine when to anticipate that. If there's been small changes, but stable changes in an echocardiogram, for me, I think the real answer is that conversation as we're talking with the client about that particular report. Look, you're going to need an echocardiogram probably in 3 to 6 months. That next one should be done with an in-house cardiologist, at a specialty center, like yours. And I think that's the piece that I think that we require a little bit more education on making that determination.
Yeah, and I think you do need to push back a little bit more on your ultrasonographers. So, I've read all of these reports, right, from companies that send them out to cardiologists who are, maybe not even in the United States or different states. And so I think people that are more removed from the area will kind of comment a little bit more. Some of them might be a little bit more forceful to say, hey, you should see a cardiologist in person. I read mobile. I've done a lot in my career. I've been in academia. I did private practice. I've started my own practice. I also did mobile. And when I would do mobile or read other people's images, if I see something that's really concerning, I will say, you should see a cardiologist in person. This is very bad. This has progressed. I read some of these reports, and it's the stock kind of response that you always get, right? Like, this is stage C, blah, and it's like verbatim what's been on the last 3 reports that you've read. No, specific. Yeah. The size of the left atrium today is, twice what it was yesterday, or last time, not yesterday, last echocardiogram. I'm concerned this patient is edging towards congestive heart failure. Thoughts would be, these sort of things. So I think the longer you take looking at the studies and comparing them to the previous ones, the more of that information you could get. But I don't think that's your fault. I think that someone is not giving you enough information, because I feel like if you read that, right, if you saw that where someone said, geez, the left ventricular dimensions are significantly increased compared to last time, or now there's new systolic dysfunction that wasn't seen before, you'd be like, whoa, this sounds bad. Yeah. But if you just keep reading, there is left atrial enlargement, there is left ventricular enlargement, which you have from last time, it's hard for you to make that call. And that's not your job. You're not a board certified cardiologist. You can't look at those numbers and know how bad that is. But I tell you guys all the time, if you don't know, if you're concerned, email me the report, call me. I'm happy to get on the phone and say, ooh, this is really bad, or no, this looks okay. Don't worry about it.
Yeah, I mean, I think that's I think we don't do enough teaching of our inexperienced veterinarians, or even some of our experienced ones who haven't worked in some of the bigger settings, that it's okay to question a little bit. It actually makes us all better, and it's likely best for the patient, which is, as the aforementioned, as long as medical quality and patient care is great, everybody's going to be winning. And I think that's key. So I'm going to put a stamp on that paper, and then I'm going to move us over just quickly to a couple other initiatives that you're running through your practice, which are a couple of studies that are currently underway. and there's likely a need for additional patients in those studies. And so, what are those studies, and what are some of the ways that the general practitioners in the area can help submit patients to that study?
Yeah, so these are studies that we're just participating in. I'm just an investigator in these studies, so I'm not the I'm not the principal investigator who's come up with these ideas. I'm not that smart. I'm just a good cardiologist. But from Texas A&M, we have the Triad study, which is the test of rapamycin in aging dogs. So we're looking at healthy aging in dogs using the medication rapamycin. So this is something we'd want for all of our dogs, right? As they age, we worry about them getting disease processes that affect their organ systems and things like that. So, rapamycin is a medication that's used to prevent organ rejection. A lot of longevity clinics will actually prescribe it to people to take. So it's looking for dogs who are over 7 years of age and between 44 to 120 pounds, which is a little tight here in New York City for that size. But almost anyone can be in the clinical trial as long as they don't have significant disease. They have to kind of go through a lot of questioning to get into what they call the dog pack, the dog aging pack. And then once they kind of go through that, they need to be screened by a cardiologist because rapamycin in high dosages can cause changes to your heart. So we want to make sure you have completely, normal functioning myocardium before we put you on this medication.
Great.
So the tough thing though is that these clinical trials, these FDA clinical trials, they you have to do everything by the book. There's lots of paperwork, and so you have to get trained. And so it's something that takes a lot of time. It's a drain on practices. It's drain on cardiologists, and so a lot of people choose not to participate. We have, because I think advancing science is really, really important. And so, we're one of the only centers in not only New York City, but the tri-state area that's able to enroll dogs into the study. Mm-hmm. So we need to have these kind of spots across the country. If someone wants to get enrolled, if they have to drive to Virginia from New York City, they're not going to want to do that.
Yeah. And then there's one other study with cats, correct?
Yeah. So the other study is the HALT study in cats. So this is run, again, by other smarter people than I, but it's looking at preclinical HCM in cats. So, as you know, cats get hypertrophic cardiomyopathy. We know once they go into heart failure, what we should do with them. We know that once their hearts start to dilate, so their left atrium dilates, we know they need clopidogrel. That prevents blood clots, but we don't have anything that actually slows down progression. This is looking at a new medication to slow progression of the disease before they go into heart failure. So the way I kind of say to people, which is maybe make some of the study investigators cringe, is I kind of compare this almost to the EPIC study where we were looking at those B2 dogs before they go into heart failure. What can we do? How long can we prolong this? Is there something we can do like that for cats, these B1, B2 cats? Can we give them a medication and prevent them from going into heart failure? And there's a lot of cat owners out there that have heard of this study that really want to get their cats into this study. And again, we're participating in it, and I'm the only cardiologist in the tri-state area that can enroll cats into that study. So if you have a cat that's been diagnosed by a mobile ultrasonographer, as having hypertrophic cardiomyopathy, whether it's stage 1, B1, B2, we can get them enrolled into that study potentially.
Awesome. Thanks for sharing all of that, Justin. I think that's super exciting stuff, especially happening locally, being able to share this out and get the word out. Hopefully you get some referrals and patients coming in to join that with you. Well, I think it's time for our wonderful new segment, Clinic Conversations, where we ask our team members to ask our esteemed guests some questions that are on their mind around the industry and the specializations that are of our esteemed guests. Today we have time for one question, which I'm excited to share with you. It comes in from one of our very own doctors, NT-proBNP. A test that does come up a lot with our teams. And I think the question kind of stems from, when is this test kind of like feeling most valuable from a diagnostic perspective? When is it not? And is routine testing of a proBNP and NT, especially in cats, is that helpful? Or is there like any kind of rhyme or reason to kind of using this test?
Yeah, so there's there's data out there, not as much data as we'd like on it. Interestingly, there's no data on following up numbers in, the same patient over time. So we don't even know that much about trends within the same patient, interestingly, which is something they do very commonly in human medicine, sometimes even treating patients based on what their NT-proBNP does. So there are definitely some breed-specific papers that are out there that can be helpful. But I think for, general practice using this in cats, the way we should be using it is dependent on the patient population you're testing. So the way I try to explain it is if you're practicing in Alaska where there's no mosquitoes, you're not, heartworm testing all of those dogs, right? Because you're going to get a ton of false positives because there's almost no heartworm there. Same thing if you test, every puppy who doesn't have diarrhea or GI signs for parvo, you're going to get false positives, right? You just don't test everyone. You have to have a clinical index of suspicion that you might have disease. And the reason why that works is there's this thing called the nomogram or nomogram, where you have incidence of disease and then your test, how well your test actually performs, and then what the likelihood of disease is after that. And so it's 3 lines that kind of intersect with that. So if you take a patient population where the incidence of disease is low and then you ask the test to perform, it's not going to perform as well. If you take a patient population that has a higher likelihood of having the disease and then you test those patients, it's going to perform much better. So we're looking at if you just test every single cat with NT-proBNP, you're going to get a ton of false positives. If you say, okay, well, is there a group of cats that's more likely to have disease? And yes, so if you have a cat that has a heart murmur, right, now their incidence of disease could be 30 to 40%, depending on which study you read. Whereas if you look at how many cats all have heart disease, depends on studies, but maybe anywhere from 1 to 10%. So our incidence is way higher. The test is going to perform better. So use it when you have a clinical index of suspicion. However, what you have to remember is if you do that test, what is the next step? So if you get a positive result, then your next step is to do an echocardiogram. However, if you have a client that comes in and you say your cat has a heart murmur, we could do an NT-proBNP. If it's positive, we have to do an echocardiogram. But if you want to do an echocardiogram right now, do it right now. Don't waste the money or time on the test, right? Because the negative predictive value of that test is much better. So if it's negative, it's very unlikely that that patient has any clinical disease that you can find. But if the owner is going to do the echocardiogram anyway because they want the gold standard, they want more information, then just go right to that. The other way I think it performs really well, or at least that we have better studies on in dogs, is for dogs who have respiratory distress. So if you have a normal or just mildly elevated NT-proBNP in a dog that has significant dyspnea, coughing, things like that, then it's much less likely for it to be congestive heart failure. So I think the ways we can use it in our practice are that way. In cats and dogs, we're sending this test out, so there is a little bit of lag time there. But I think it can perform well if you're using it on the right type of patients. But again, I think you have to talk to your clients about what they would do anyway, because you don't want to waste money if they would go for the additional testing, regardless of what that test says. Sometimes it helps you though. Sometimes you have clients who might trust numbers or machines over their doctors. Yeah. And so if there is a number that says something, then that can help you convince them to go the extra mile for the next test.
Yeah. Wow, that was a very thorough answer. I really appreciate that, just from your mouth to our listeners' ears. I loved having you on today. I'm going to wrap us up because we covered a lot of topics. I'm really happy about that because, we make the most of the time in the studio. I think we all 3 already know that. If you listen to the last episode, we fit a lot of topics into that as well. Justin, where can the folks find you?
So the Animal Cardiology Center is www.tacvets.com. So all of our information is on there. As far as finding me personally, if you have any cases or questions, you can always email me directly, which is just my last name, Carlson @tacvets.com.
Awesome. Well, thank you again, Justin, so much.
Thanks for having me.
Thank you, Jeremy.
Thanks. Yeah, we're looking forward to having you back.
Yeah. All right. Bye, everybody. We'll see you soon.